Hello and welcome from Munich in 2018. It's the ESMO meeting with over 25,000 delegates. I've got two of them with me here today, two old friends of mine. Bertrand Tombal from Belgium, a professor of urology with a special interest in prostate cancer. And we've known each other for a long time, based around the EORTC days originally. My great friend Matt Galsky from New York. And Matt and I have been working on bladder cancer for years. We went through the quiet periods of bladder cancer together, and we're now going through the noisier periods. I'm not sure outcomes have improved that much yet, but we're hoping that's going to change hugely. And some of the data we saw today suggests that might be the case, and clearly new immune therapies and targeted therapies. But before we talk about bladder cancer, Bertrand, I wanted to come to you and maybe talk a little bit about what you've seen at the meeting at ESMO this year that you were maybe most impressed with.
So there were a lot of, once again, practice-changing abstract coming from the UK mostly, but when it comes to precision medicine, we had a series of interesting studies. One of this was a study comparing AR pathway inhibitor, abiraterone or enzalutamide, to cabazitaxel in these patients that are considered as aggressive phenotype or poor risk, selected because they have a short response to ADT, they have an aggressive feature. And when we speak amongst each other, there's been that contention that these patients would be better candidate to chemo than to Abi-Enza. And this is something every time everybody's speaking about sequencing, and even at the APCCC, the big St. Gallen conference, people would say, no, these patients, we would rather give chemotherapy. So kimchi compare Abi-Enza to cabazitaxel. And I would say, not surprisingly, they unfortunately all die very rapidly. Yeah. But there's no difference, at least no significant difference between Abi-Enza and cabazitaxel. So it's a little bit counterintuitive.
Can I push back a bit and say, so what's precision about that?
It was about the fact that kimchi has tested a series of prognostic markers such as P10, RB loss, P53, DNA repair mutation, and it was thought that they would actually predict a phenotype that it's most likely to respond to cabazitaxel than to AR pathway inhibitor. And actually, except for well-known already AR aberration, when you're coming first-line treatment, doesn't seem to make a difference. So basically, I would say that it's not going too much into using precision medicine test at early stage of the disease.
Why has precision medicine been so difficult in prostate cancer? What breast cancer seems to nail it, and hemato-oncology?
I think for three reasons. The first one is that the tumor is unbelievably heterogeneous. Right. The second is that we hadn't had tests that were performing as well as in other cancer type. As you know, in prostate cancer, because the disease is mostly in the bone, it's difficult to get a good biopsy. As this regard, there was another poster showing promising result that you can get most of the information you need from ctDNA. But when you look at that, you see that we are still very, very, very far away from having a commercial test. And the third one, probably the most important one, is that actually addressable mutation, it's like winning the lottery. It's like then altogether it takes 10 to 15% of patients altogether. So I would say that's the three reasons why we're still struggling to be like, at EORTC, I see all my friends doing like lung cancer trial. And then I say, why don't we do the same? And I think it's not because we are bad, it's just because we're dealing with a totally different disease.
And perhaps to push back a little bit, the AR is probably one of the key examples of precision medicine in oncology in the history of oncology, right?
Yeah. So but it's a very basic one.
And it's a ubiquitous driver, so that even though it's very precise, it's present in the majority of patients and it's driving disease.
Yeah, but then you could even argue that, you don't need to be a genius to know that if you give 2 or 3 lines of AR targeted therapy, you're going to basically deteriorate the AR, that it's going to make totally it's going to be make non-functioning. And actually, all these, if you take something like ARV7, that was very popular, it was tested after 2, 3, 4 lines of treatment. when know what we want is know that we move all these drugs very early on. What we want is earlier information. And for instance, if you look at something like ARV7 on prostatectomy specimen or on very early disease stage, that's not necessarily helping a lot.
Just the ARV7 story, because you mentioned it, perhaps just tell us where we are. It looks so promising 4 or 5 years ago. I remember getting off a plane from ASCO, and it was the big thing. And now I was in a meeting earlier yesterday, and it seems to have disappeared. What's going on with ARV7?
I think that, first of all, same observation I mentioned before, we don't have a very robust test. So, and there is a lot of inconsistency across platform to look at ARV7. Also, for instance, Johan de Bono has shown nice data where you have a correlation between the number of CTC and the ARV7 expression. So what people now believe is that actually it's like a proxy for bad cancer.
And it was thought to be a proxy for response.
And it was to be a huge, so basically it's now not used that much because, as you may understand, I mean, the idea was that if you have received enzalutamide, could you predict who need abiraterone?
Yes.
But then we've got like 2, 3, 4 trials that show that on the whole, only 4 or 5% of the patients are responding to the second-line treatment. So having marker that predict who's going to respond to a second-line or hormonal treatment,
which was the game, which was the aim of AR7.
The big game, like in 4 or 5 years ago, is not a question anymore. In UK, for instance, you can't get both.
So the trial that you described, even though patients hadn't been exposed to both next-generation hormonal therapies yet, seems to be a perfect trial to test the AR. Was that tested, ARV7?
We still have preliminary result. It just shows some result, but I think that, I mean, we've seen all since then that AR amplification in general, or it's more than AVR, it's, losing the ligand binding domain, amplification, many mutations. So it's like one of many, alterations, which, if you take a population who doesn't respond to AB and you look at ARV7, yes, it's going to be enriched in ARV7. But sometimes people are asking me, should I invest in my clinic into an ARV7 test? I would say no.
No at the moment. Bladder cancer, are we making more progress?
I think we are making progress. I think the progress in bladder cancer has been after a period where we really had nothing that showed a lot of gains, and so there was a lot of enthusiasm about immune checkpoint blockade, and certainly that has changed the landscape, but I think we've pulled back a little bit as we've really seen the proportion of patients that benefit from these treatments. That said, in addition to this huge field of exploring combinations to try and increase the likelihood of responding to immune checkpoint blockade, clearly there seems to be some value in moving these treatments earlier in the course of the disease, and that was a big theme at ESMO this year. 2 key abstracts. One, the first abstract, looking at immune checkpoint blockade in patients with BCG unresponsive non-muscle invasive disease, Keynote 57, an early look at this data, but in patients with carcinoma in situ showing a 38% complete response rate at 3 months. It's an early time point, but the very fact that there is activity in this early disease state with the systemic therapy is certainly encouraging. This is a large patient population in a patient population who would otherwise be treated surgically with cystectomy. So I think this is a key unmet need, and we'll need to watch this data for longer follow-up.
There was some neoadjuvant data at ASCO too.
Yes.
We know the second-line response rates and overall survival benefits are modest. Why are we seeing activity? Why are we seeing this activity earlier in the disease? Is it greater than you would expect? And if it was, why is that the case?
It's a little bit greater than I would expect. I think we have seen a hint of improved activity as the treatment's moving earlier in the course of the disease, from platinum-resistant to first-line treatment to the neoadjuvant setting and now to the non-muscle invasive setting. The increase in response rates, it's not doubling or tripling, but it's increasing a little bit as you move earlier in the course of the disease. I think there might be some biology there. We know in patients with metastatic disease, patients with lymph node-only metastases seem to respond better to immune checkpoint blockade, so that's something about the biology, and maybe we're seeing more of that type of biology the earlier we go. We know that happens with chemotherapy too, in terms of the complete response rate seen with neoadjuvant chemotherapy versus in the advanced metastatic setting.
And also, if I may, because as a urologist, I mean that, cystectomy is there because this is the only treatment we have. It's not something you would like to have. And we tend to forget that the bladder cancer population in most European countries is a population of it's elderly patients. It's absolutely not rare that in the MDT we discuss cases of 82, 83, 85 years old guy. And so far, I think that the view on the neoadjuvant has been to reduce the tumor load before you do the cystectomy and you gain something after that. But I think that it's basically opening a totally new dimension, which is, can we cure that disease by systemic treatment only?
Yeah.
So can we, in those, and that's where we urologists, we still have a lot of work to do, trying to really define what is a complete response.
So Bertrand, just on this issue, what you're saying, which is important, is you're saying we're going to try and replace cystectomy?
At least I would say postpone cystectomy, because we learned something very, very interesting, and especially with Ronald DeWitt Pembroke study, that most of
the non-muscle invasive study.
Most of the patients, when they progress, they do so through non-invasive cancer.
Yeah.
So meaning that you still maintain the window of opportunity
Yeah.
for radical surgery. And that was very well presented by Sharok Shariat, which is a urologist as well, saying that that's reassuring that when they progress, it's rather a minority who develop muscle-invasive disease. So I think now we can slowly start with the concept of saying you give neoadjuvant treatment. You have a lot of options for patients that are unfit for chemotherapy, because that's, once again, when they're 85, they have already a lot of comorbidities. And that, instead of jumping on them, you create a kind of window of opportunity when you can, I would say, apply active surveillance and try, because if tomorrow you can reduce the rate of cystectomy by 45%, which would be in line of the complete response rate, for this patient, that would have a major impact.
And I have to admit, I was a little bit nervous about giving systemic treatment that has a relatively good safety profile, but some bad things can happen in patients with non-muscle invasive disease. But I think this point about delaying cystectomy while also perhaps providing some systemic coverage, because we know that giving these patients intravesical therapy has been done in the past, not only has that not been associated with robust response rates, but you always worry a little bit about the disease becoming systemic.
That's always what we say to the patient. The patient who has like 6 cycles of BCG has not complete response. We say, the problem in bladder cancer, we always too early, too late. If we give you another 6 cycles, it may work. But it may be also that if it doesn't work, you're going to get lymph node by the time. So I think that immune therapy by BCG has its limit. So clearly, this is opening a totally new, and I hope, and this is a message for urologists who are looking at us today, I hope we're going to be clever enough to see what are the potential to basically better select patients who don't need surgery.
So I'm going to ask Matt that question. Talking about patient selection in bladder cancer right now, are we going to use biomarkers or are we not? And if we are, what are they going to be?
So there are 3 trials right now that I know of, and probably more, seeking to define a patient population with muscle-invasive bladder cancer that might be treated with systemic treatment alone in a curative fashion. 2 of those trials are using DNA damage response gene alterations to select patients to achieve a clinical complete response for surveillance rather than cystectomy. One of the issues with those trials, although incredibly innovative and paradigm-shifting trials, one of the challenges is that the lists of genes in both trials are different, and that really begs this question: how robust do those biomarkers need to be validated before they enter a trial like this? The third trial is really asking an old question in a new way, and it's asking, what is a complete clinical response? How do you define that? What tests do you need? And if you really define it robustly, can you select patients who don't need to have a cystectomy?
Yeah, that's where we have work to be done on imaging and post. If you look, many of the urologists, they do the cystectomy not having re-resected the patient. And maybe we should do that and then do the cystectomy. We need to have trial to validate the definition of complete remission, because as long as we don't have this specific trial, any further development will be made very complicated.
And this is a biomarker. Complete clinical response is a biomarker, and it should be defined and validated as robustly as any other biomarker.
I've just got 30 seconds to go. So one key message from both of you about what you've seen today or the last few days at the meeting in precision medicine in prostate cancer, the take-home message from your perspective, Bertrand.
I would say that for prostate cancer, last year I was still thinking it would be a dream. Actually, it's not a dream, not because of the drug. The drug works in prostate cancer, but because we're getting much better and developing tests to find a few patients that are likely to respond. However, the bad side of it is that for the prostate, it's still a little bit like winning the lottery. It's going to be less.
There's so few patients.
There's so few patients, but these patients, they can live forever.
And that bladder cancer, where are we?
I would say that earlier use of immune checkpoint blockade is going to be the near-term future, but so far we have single-arm phase 2 studies, and we really need randomized studies to establish the benefits of this strategy.
I'm going to thank you both. I'm going to tie this up. Thank you for listening, and see you soon, I hope.